We are on live. Dirga ma'am, you can start now.
We are still waiting for Dr. Shadab and Dr. Neeraj to join.
My optoms might also join, okay? They'll be silent spectators. I hope that's okay.
Yes, sir. Yes, sir. Absolutely. Have coffee.
So until people join, Dirga and Divya, why don't you tell me how the system is right now for learning phaco? As in, you're doing a case, are you recording videos? Is this being discussed? How are you learning? Or is somebody standing with you for every case?
Yes, sir. So I have finished. I completed my fellowship in January 2024. And in the last 6 months only, we start doing FACOs. And yes, the initial sessions are all moderated. So, and yes, we have our recorded sessions we have our recorded videos as well, and then we have regular classes. So, we discuss the cases, we discuss the complications and everything.
So monthly a discussion of complications are there also.
Okay, that's good. So you have all your videos with you, right? You've kept them.
Yes, yes.
Yes.
Yeah, that's how you're going to learn, by reassessing those videos.
Yes, sir.
Hi, Ameya.
Hi, Neeraj, how are you?
Yeah, fine. But
Neeraj
my
and me.
voice is,
Huh?
my throat is totally messed
Oh,
up.
no. So Neeraj and I have been together since MBBS. We did MBBS together, DNP together. We studied for postgraduate entrance together. We got into Sankara. Then we did fellowship together. We were in Kanpur together for a year.
What about Shadab? Is he?
I don't know, man. He's supposed to come now. I have my phone also. Can you call him, Dirga? So Divya, where have you read phaco from?
Sir, I'm in, sir, I will start after 6 months, sir.
You start doing after 6 months. But what about
Yes,
reading?
sir. So reading, sir, I'm not reading from anywhere, sir.
Like I am. Go read Siebel before you start.
Yes, sir. So I'm
There,
watching videos, sir.
it's not enough. It's
Yes,
not
sir.
enough. You need to know the theory. So
Yes,
before you start, in fact, me and Neeraj know we have during our times during DNB, we had made PDFs of each and every topic in opthal by reading from
yes,
all of the major books. I don't know if you guys have that. So okay, so that includes FECO, that includes CBIL. So everything is properly underlined. All the
yes,
nonsense stuff which is not required, you can just skip. So it helps. So the hard work has already been done.
yes, sir.
So Dr. Shadab will take a minute or two more. He's just logging in.
So is this class mandatory for all the IOL fellows or is it elective?
Yes, sir. We circulate the group across like all the circulate the link and it is available to IOL fellows Pan Shankara. And
Available is okay. Is it mandatory or is it voluntary?
it's not mandatory, sir.
Hmm.
Dr.
So
Ameya.
once and then we'll start.
Okay, just a second. Hari, are you there?
Yes, ma'am.
Yeah. So next minute, please go on live.
Imagine having invention.
We are on live, ma'am.
Are we live?
Yes, ma'am.
Okay.
Right.
Good evening, everybody. Today, I'd like to welcome you all to yet another episode of our Cataract Series. And the topic for today's presentation is Understanding Astigmatism. On the panel, we have with us Dr. Ameya. Dr. Ameya Ingawale, he did his post-graduation from Sankara Eye Hospital, Coimbatore, following which he did his fellowship in cornea and refractive services at the same institute. And currently, he is the director of the Eye Hospital in Thane, the Eye Clinic Eye Hospital. We also soon, Dr. Shadab will join us. Dr. Shadab also did his, after completing his post-graduation, he also did his fellowship in cornea and refractive surgery from Shankara Eye Hospital, Coimbatore, and currently he's working as a consultant at the Green City Eye Hospital, Nagpur. We have Dr. Neeraj Shah. He's also the moderator for today's session, and he also did his fellowship in cornea and refractive from Shankara Eye Hospital, Coimbatore, and he is the Chief Medical Officer and consultant of cataract, cornea, and refractive surgery at Shankara Eye Hospital, Jaipur. The presenter for today's session is Dr. Divya Khandelwal, who is currently pursuing her IOL fellowship from Shankara Eye Hospital, Jaipur. Dr. Divya, please start the presentation.
Good evening, everyone. Today's topic of discussion is Understanding Astigmatism. Just a minute. Is my PPT visible?
Yes, yes. Please go ahead.
Just a minute. Actually, it is not going ahead. The next, I am not able to go to the next slide.
You'll have to remove it
Stop
from the
sharing
presenter
and
mode.
restart sharing, doctor.
Yes, ma'am.
Dr. Shadab has joined us all. Hello, sir.
Hi everyone. I think if the PPT is not moving forward, that means we have all understood astigmatism. So that is,
We wanted Dr. Shadab on board for such deep insights.
Yes, sir. So now it is going forward. So astigmatism is a distortion of light entering the eye and coming to a focus at multiple points, either in front of the retina or behind the retina or both. So, depending on the nature, astigmatism is of two types: regular astigmatism and irregular astigmatism. In regular astigmatism, it exists when two principal meridians are 90-degree apart. It is more common, mainly seen in younger patients, and it has bow tie pattern in which steep and flat meridians axes are perpendicular to each other, and it can be fully corrected with a cylindrical lens. Now, irregular astigmatism, whenever the two principal meridians are not symmetric and do not lie 90 degrees apart, not orthogonal, it is less common condition and it is always a pathologic condition. And causes include epithelial membrane, basement membrane dystrophy, corneal degeneration, corneal scarring, pterygium, keratoconus, any ocular surface disease like dry eye, or any prior corneal surgery. And unlike regular astigmatism, it cannot be fully corrected by cylindrical lenses. Now, depending on focal lines, astigmatism is of following types, like simple myopic astigmatism when one point of focus is on fovea and another is in front of fovea. Simple hyperopic when one point is on fovea and other is behind. Compound myopic when focal points both are located in front of fovea. In hyperopic, both focal points are located behind fovea. And in mixed, one is in front of fovea and another is behind fovea. Now, depending on location of steep axis, astigmatism is of three types: with the rule, against the rule, and oblique. With the rule, astigmatism exists when steep axis at vertical meridian, against the rule when steep axis is at horizontal meridian, and oblique when steep axis at angle not aligned with vertical or horizontal meridian. Now, based on etiology, astigmatism is of following types: lenticular or corneal. Now, in corneal astigmatism, different parts are anterior corneal astigmatism and posterior corneal astigmatism, and both sums up to total corneal astigmatism. And plus, surgical induced astigmatism will amount to net corneal astigmatism. In posterior corneal astigmatism, as we all know, posterior cornea is steeper in vertical meridian in more than 90% of cases. So its surface is concave and so act as minus lens and induce against the rule astigmatism. And it creates net power along horizontal meridian and induces a mean power of minus 0.3 diopter. Since astigmatism is a vector quantity, that means it includes both magnitude and axis. So it will be incorrect to compare pre-op and post-op magnitudes of astigmatism without regard to their respective axis. So to introduce this, Elpin's method is introduced by Dr. Noel Elpins in 1993. And this method of astigmatism analysis enables the examination of results of astigmatism treatment measured by both refractive and corneal measurements using vector analysis. And by examining individual vector relationships of surgically induced and target induced astigmatism, a comprehensive astigmatism analysis is completed. And vector planning should be used in cases where a discrepancy exists between the corneal and refractive astigmatism, and this discrepancy is quantified through a calculation called ocular residual astigmatism, which is a difference between corneal and refractive astigmatism. This is the diagram showing Elpin's method. Initial diagram is in this pre-op astigmatism is 3 diopter at 30 degrees and targeted is 0 at 30-degree axis. And second diagram is representing fully corrected astigmatism post-op, in which both surgically and target-induced astigmatism is at same axis and of same magnitude. Now coming to management of astigmatism in cataract surgery. With about 87% of patients with cataract having astigmatism, management in cataract surgery not only yields an improved unaided visual acuity and image quality, but also higher patient satisfaction. This is representing cylindrical distribution in patients. Moderate in 25% of patients, 1 to 2 diopter of cylinder exists, and severe, more than 2 diopter of cylinder is seen in 10% of population. So, what are the pre-op imaging for the treatment of astigmatism during cataract surgery? First, careful history, then slit lamp examination, including tear film testing, fundus examination, corneal topography, and keratometry. Some intrinsic factors are also important, like tear film composition, ocular surface status, epitheliopathy, or whether patient is contact lens wearer or not. Corneal topography. First, we have to look at the pattern of astigmatism, whether it is regular or irregular. And patients with conditions such as Salzmann nodular degeneration, anterior basement membrane dystrophy, corneal ectasia will mostly have an irregular, non-symmetric pattern. So this should signal the need for additional examination before proceeding with refractive cataract surgery. And often patients with corneal lesions such as basement membrane dystrophy and Salzmann nodules will benefit from treatment with superficial keratectomy to restore normal corneal shape and regularity before cataract surgery. And it is also helpful in ruling out dry eye disease. Now keratometry, 3 identical keratometry readings, reliable readings should be done, and compare both eye keratometry, mainly the steeper axis, and recommend the comparison of data from more than one modality, looking for agreement to confirm axis and magnitude and thereby minimizing errors. Now, these are some common instruments used for keratometry, like manual keratometry, which is based on doubling principle, autokeratometry, based on refractometry, optical biometers, which analyzes the pattern of reflected light from cornea, topographers, Placido test technology, and pentagram Scheimpflug technology imaging. And in this, only optical biometers, which are new biometers, posterior keratometry of posterior corneal astigmatism is included. And in pentagram, also it is included, but it is not reliable, as this is published in this article of American Academy of Ophthalmology. Currently, the posterior corneal power is calculated with the assumption that there is a fixed ratio between the anterior and posterior curvatures. So it is not reliable in any of these methods. Now, astigmatism in cataract surgery. There is pre-existing astigmatism and surgically induced astigmatism. So surgically induced astigmatism is astigmatism that develop after cataract surgery due to incisions made in the cornea. And then centroid surgically induced astigmatism, it represents the average or central point of this induced astigmatism, providing a single value to describe the overall magnitude and axis of the astigmatism created by the surgery. And essentially, it's a way to calculate the center of mass of the astigmatic change caused by the incision, which was also introduced by Elpin's method. Now, pre-existing astigmatism, we have to consider the amount, axis of cylinder, and the status of fellow eye. Now, these are the different modalities of correcting astigmatism. In pre-op astigmatism, we have to plan cataract incision on steeper axis. then different corneal relaxing incisions like limbal relaxing incisions, opposite clear corneal incisions, and arcuate keratotomy, and toric IOLs. Then limbal relaxing incisions and CCIs, they are 180-degree to main incision, enhances the flattening, and 90-degree to main cataract incision will neutralize the flattening. And post-operatively, for post-operative refractive surprise, we can also plan corneal laser ablative procedures like LASIK and PRK. This is CRS clinical survey result 2014, which describes that in higher astigmatism, toric IOLs are planned, and in astigmatism lesser than 1 diopter, on-axis incisions or manual LRIs or AKs and femtosecond laser LRIs or AKs are also reliable. Now, clear corneal incisions induces more astigmatism than sclerocorneal tunnel incision. And location, the farther the incision from the center, lesser is the surgically induced astigmatism. So surgically induced astigmatism is directly proportional to the length of scleral incision, and it is inversely proportional to the distance of incision from the corneal center. Now we are coming to incisional procedures, LRIs versus arcuate keratotomies. Approximately place 90% depth in the steeper meridian. They have coupling effect. The longer, deeper, and more central, greater astigmatic correction. And one is made anterior to vascular arcade versus mid peripheral. They measure magnitude and axis. First, magnitude and axis is to be measured before planning them, and to choose surgical plan based on the nomograms. Then identifying accurate thinnest pachy at the intended site of incision, and incision of precise length and depth should be there. But there are some disadvantages of incisional procedures, like regression will be there, more astigmatism, higher the regression, mechanical instability. They are prone to these incisions are prone to globe rupture or trauma, and can correct astigmatism lesser than 1 diopter. Also, their results are not predictable and they are irreversible. Then coming to toric IOLs, it corrects astigmatism in the IOL plane. Standard toric IOLs available cylindrical parts are from 1.5 diopter to 6 diopter. They are available as monofocal and multifocal, and no extra damage to corneal structures. Their results are predictable and they are also reversible. Thank you.
Thank you, Dr. Divya. That was quite informative. I'd like to request our panel members to take over the discussion and give their opinion on the presentation.
Okay, so I'll just start with a few points. What she explained about vector analysis, is the video visible by any chance of mine?
So,
Yeah.
Yes, sir, it is visible, sir.
Okay, like on YouTube also, this video would be what is seen right
No,
now, right?
sir, there will be 2-3 seconds the gap
Lag.
between the telecast.
Okay, so I just want to explain in little simpler words what she meant by all this vector analysis. Now, just imagine if a car is moving in this direction and somebody has to stop the car. So the opposing force has to be opposite to it. So that's what, if this car is going with a certain amount of force, to stop it, the neutralizing force has to be 180 degrees opposite to it. So this works in the world of physics, in the real world. But in astigmatism, the opposing force is not at 180 degrees. It is at 90 degrees. That means that if you make a temporal incision and induce an astigmatism along the horizontal meridian, the neutralizing force would be an incision in the vertical meridian, like a superior or an inferior incision. So this is why we need to do a proper vector analysis, understanding something known as a double angle. Okay. Now you need not actually understand any of these vector analysis. You need not do the vector analysis yourself. But why is it important to understand that such a thing exists? Is because you cannot simply subtract the K values and understand what is the astigmatism. Like for example, if the pre-op astigmatism was 44 along the vertical and 45 along horizontal, so the difference is 1. So you might think, okay, pre-op astigmatism is 1. Now let's say post-op, the vertical becomes 45 and the horizontal becomes 44. What is the difference? The difference is again 1. So you might think, okay, great, I have not induced any astigmatism. But that is not true. You have actually induced 2 diopters of astigmatism, because it went from 44 and 45 to 45 and 44, which is actually a difference of 2 in a vector diagram. It's vectorially, it is opposite. Okay, it's like going from -1 to +1, which is a difference of 2. So you need not actually learn this yourself. There is an SIA calculator online. You can just go to the website, register on it, and that's where you have to just put entries of your patients. So you need to put your data pre-op, and you need to do it post-op. Now, if most of you, I'm assuming, are working in Sankara as IOL fellows. So what I would recommend you guys to do is make an Excel sheet. Whenever you operate a phaco patient, put down the pre-op findings, put down the name of the patient and the village that the patient is from. Usually, most of the camps in Sankara are repetitive. They're from the same place every month. So the next month, like every single Monday, what you do is you see which camp is coming. If it is from one of the camps from which you had operated a patient previously, you just look at the list. Maybe your patient has come back for the second eye. So then you take the patient, do an AK, a keratometry, and find out what is the difference. So, and then you can populate it onto your SIA calculator sheet, which is there online for free. By doing this regularly, if you during your tenure in Sankara, which is 6 months or so, even if you can get around 200 patients data, you will have an idea of what your SIA is, how much astigmatism you are inducing as a surgeon. And then you can, so later on when you come out of Sankara, you'll be able to do Toric IOLs with more confidence, because you'll be able to put your SIA in the SIA calculator, in the Toric IOL calculator, and get more predictable results. Now, another thing she mentioned was that you can take the incision on the steep axis. Now, there are some surgeons who do that. I don't deny it, but in general, it's better to just stick to one place where you sit. Like if you sit temporal, just sit temporal. If you sit temporal, just make your superiotemporal and inferiotemporal incisions, because the surgical limbus is different at different places. Like for example, the conjunctiva inserts more anteriorly superiorly, it inserts less anteriorly temporally. So when you make a temporal incision, you end up making an incision which is more in the periphery, nearer to the actual surgical limbus. So you will induce less astigmatism. Whereas if you're sitting superiorly and making a superior incision, your incision will invariably be anterior to the anterior insertion of the conjunctiva, which would end up being closer to the center of the cornea and thus induce more astigmatism. So you might induce different surgical astigmatism based on your incision location. So which will not be predictable for you in your practice. So it is better to stick to one location so that you know what your SIA is for that particular location. Now, another very important point for inducing astigmatism is wound distortion. Other than the size of the location, the size of the incision, as well as the length of the incision, the most important point is actually wound distortion, where if you keep moving your phaco probe, or if you pull the eye up, pull the eye to the side, and so on, it distorts the corneal lamellae. It also predisposes you to a wound burn, and a wound burn again can distort the corneal lamellae and induce a lot of astigmatism. So to prevent that, ergonomics is very, very important. If you are sitting temporal, make sure that your incisions are superiotemporal, inferiotemporal, so that your wrists are at a very comfortable position and there's no twisting, so that it doesn't happen. Now, many people by default first make a side port temporally, and then they make the phaco port somewhere else, and then the angles are not right. So you got to figure out what is good for you ergonomically, such that you're not distorting your incisions. Yeah, I think that's about it from me. Dr. Shadab?
Yeah. Can you hear me? Yes. So thank you, Amay, for that detailed explanation also. And what I feel is in the last 6 months of the fellowship training, this should be done. Not in the first 6 months, because what happens is in the first 6 months, you are learning phaco. So there are multiple things which can go wrong with the incision initially. So you might have more corneal edema. You might also have wound burn because you've used more energy. So you do this calculation in the last 6 months of your fellowship training, because that by that time you'll be well versed with the technique of phaco, and you will now get your SIA properly. Also, what I have seen in my practice is if you make an incision of less than 2.8 millimeters, SIA does not matter so much. Your SIA, you induce a very low SIA of about zero point 0.2 or 0.3, which in totality might not create a very big issue when you're planning for toric IOLs or something else. Also, I am not a very big fan of LRIs or AKs because being cornea fellows, we've seen multiple corneal problems. Not maybe because of LRI or AK, but because of some things like an RK. Like an RK is similar to an AK, which is done peripherally. RK is done centrally. So we've seen a lot of patients who have RK incision prolapses and incision people having burst of incision and go collapse and everything else. So I think, and the second most important point is it's not predictable first, and second thing, I don't think it's permanent, because the cornea is a living tissue. It changes rapidly, and your the wow effect which you get on the first post-op day or maybe through the first 6 months or so with doing an AK or LRI goes off in some time. Even with corneal, even with CL or contact lens, you should know whether the patient is wearing contact lens or not. Soft contact lens, maybe not more than 15 days gap you'll have to keep. But for rigid contact lens, or now a lot of people are wearing mini sclerals for multiple reasons, for keratoconus specifically, or and other reasons also. You need to know how much contact lens wear is there and whether that is warping the cornea or not. I don't know about Salzmann nodular degeneration, whether you remove it and then you get your keratometry properly and then afterwards it might recur. So it may not be a very good option to put a toric lens in a patient with a Salzmann nodular degeneration or with somebody having irregular astigmatism for that matter. Secondly, what I see in a patient with astigmatism is whether both the corneas do have a mirror image of the of the bow tie appearance or of the same thing. If that is the case, even with astigmatism of high diopters, or even with astigmatism which look a little irregular, might be a good case for a toric IOL, because you have symmetrical findings in both your eyes. That may be a normal variant of the astigmatism, but not in cases where you have only in one eye asymmetric bow tie, the other eye is absolutely straight. You might be having a progressive problem which you don't want to treat with the toric IOL. Might as well do a normal monofocal IOL and give the patient glasses. Also, something else which I wanted to, I don't know whether many people, they do have this concept that they want to correct the against the rule astigmatism of lesser diopters, but they don't want to correct the with the rule astigmatism of even one diopter, because they feel that even with having with the rule astigmatism of one diopter, you do have some amount of multifocality, the near vision is a little better or something like that, which I have not come across a lot in my practice. Maybe Neeraj and Amay can shed more light on that. What is the cutoff for you for putting a toric IOL? What is the least amount of astigmatism which you want to correct? What I do is I correct whatever astigmatism is there in multifocals, but for monofocals and looking at the patient's profile, I do not correct less than one diopter of astigmatism in patients who have less than one diopter, maybe up to one diopter, I do not correct. So Amay and Neeraj can tell in detail about that. And yeah, that's all.
Okay. So I completely agree with Shadab with respect to his first point that LRIs, in general, all the incisional methods of controlling astigmatism, it could be LRI, it could be opposite clear corneal incision, all of them are highly unpredictable. If you make an opposite clear corneal incision, you might make it deeper, maybe more peripheral, less peripheral. It's very difficult to predict. LRI, the depth has to be 90%. How do you know what is the thickness of the cornea over there? No instrument measures corneal thickness at the periphery correctly. The pentacam measures it only up till 8 millimeters. You don't have a touch pachymeter over there, which is going to measure at the place that you're going to do an LRI. So in one cornea, the thickness might be 650, another one it might be 700. So one of them you're doing 80%, another one you're doing 90. The 81 is gaping less, the 91 is gaping more. You never know what's happening. You cannot predict it. And like Shadab said, corneal remodeling changes everything. So the effect is short-lived, and it changes everything in an irregular way. So not only are you inducing astigmatism, you are inducing the worst kind of astigmatism, which is irregular astigmatism. So both me and Shadab, I think we are very much on the same page with respect to incisional methods of attempting to correct astigmatism, in that you should just not do it at all. Now, so in short, the go-to for correcting astigmatism with respect to cataract surgery is only and only toric IOLs, according to me. Now, why is LRI still a thing? This is my hypothesis. I may be wrong, but because femtosecond laser cataract surgery is available and people are using the femtosecond cataract systems to make the incisions as well as the rexes, they use the same system to make the LRI. So from that perspective, it has there is a financial point to it, which is why I believe it is still persisting. You will find that LRIs are more prevalent in those centers where femtosecond lasers are available, and centers which do not have femtosecond lasers almost never do LRIs. Okay. Now, next point, as to like Shadab said, that people believe that leaving a bit of with the rule astigmatism induces multifocality. So actually, it does not leave any. You cannot call it multifocality because it's not a focal point at all. What you're having is one focal line somewhere and another focal line somewhere else. It definitely induces distortion, so there is no focal point. Instead, there is only a circle of least confusion, which means that the vision is never great. So you're getting some amount of maybe extended depth. You can't even call it focus. Some amount of extended depth, but at the cost of quality of vision. So I would definitely not recommend that. My recommendation is definitely you must correct all the toric astigmatism, all the toricity that there is. You only have to correct corneal toricity because obviously you're removing the lens. So there is no question of correcting lenticular astigmatism. Now, about the cutoffs, I personally don't follow this one diopter rule at all. I put every single patient of mine gets the data is entered into Barrett toric calculator, and then based on whatever the Barrett toric calculator recommends, I would go with that. Now, point to be noted, Barrett toric calculator does not always recommend the correct IOL. It gives 3 IOLs and it then tells you one of the correct IOLs, but often that is not the correct one. In general, your guiding principles should be that among the 3 IOLs which Barrett toric gives you, if you have ever seen a Barrett sheet, you will see that it gives you 3 options. So among the 3 options, your guiding principles should be, first, try to select the option which leaves the least amount of residual astigmatism. Okay, like for example, it will tell you if you were to put 1.5 diopter cylinder, the residual astigmatism will be, let's say, 0.3 at 90 degrees. If you were to put 2.25 diopters, it will be 0.1 at 90 degrees. And then if you were to put 3 diopters cylinder, it will be, let's say, 0.3 diopters at the opposite axis now, 180. So the first point to be noted is you should take the one with the least astigmatism. Now in the Barrett sheet, if you have 2 options which are giving the same amount of residual astigmatism, let us say if you put 2.25, it is giving, let us say, 0.2 diopters astigmatism at 180 degrees. And if another one, if you were to put plus 3 diopter cylinder, it is giving you the same amount of astigmatism but at 90 degrees. So in that case, if 2 of your options are giving the same amount of residual, you would prefer to choose the one which leaves with the rule astigmatism. Now, Barrett, it shows you in plus cylinders. That means that with the rule astigmatism would have, in your Barrett sheet, the cylinder would be at 90 degrees. So in your Barrett sheet, you should basically select that cylindrical power, which is number 1, least amount of residual astigmatism. Number 2, closest to 90 degrees. So at least this is what I do. So because of this, and I happen to live in a rather affluent area, so most of my patients can afford toric IOLs. So out of 100 patients of cataract which I operate, I would say at least 80% are toric, whether they're multifocal, monofocal, whatever it is.
Dr. Shadab, would you like to elaborate on what is the difference between axis and meridian? Dr. Ameya?
Yeah. So this is a big confusion in ophthalmology, uh, which is unfortunately rampant. It's there in the books also, and it's a big confusion. So the power, as in the power along which line the power is there, that word should be meridian. Okay. So if you say that the cornea, the steeper dash of the cornea, you should say the steeper meridian of the cornea. That is the correct way to put it. So if it says 44 at 90 and 45 at 180, so the correct thing to say is actually the steeper meridian is at 45 and the flatter meridian is at 44. Actually, the correcting cylinder. So if the steeper meridian is at 45, the correcting cylinder would be at if the correcting cylinder, if the steeper meridian is at 90, then the correcting cylinder could be at 180, depending on whether you're taking plus cylinder or minus cylinder. So the correcting cylinder's degree, that is called as the axis, whereas the power induced by whatever is the curvature of the thing that you're measuring for, in this case, which is the cornea, that is the meridian. So the correcting cylinder axis, the actual thing being measured, meridian.
Yeah, so we measure meridian by our topographers, and we correct it by spectacles or by contact lenses with axis.
Yeah. So we mention
The
the
correction
axis.
is by the axis. So whenever you have to give a spectacle correction, you mention axis. But for a calculation for IOLs, for biometry, you have to use meridians, like the meridian of the keratometric value with their axis, like with the meridian value.
So the way to remember this is, just imagine a cylinder. If there is a cylinder, like an actual cylinder, okay, it would, let's say you have kept the cylinder horizontally. So obviously its curvature is
You could
vertical.
show the water bottle as the example.
Yeah. So this is a water bottle. If this is a cylinder, so the cylinder is curved vertically. Okay, there is no curvature horizontally. Horizontally, this thing is flat. So vertically, it is curved. But this is the horizontal thing is the axis of the cylinder, because this is the axis, whereas the curvature is vertical. So the meridian is this, and the axis is this. That's how it is.
Do you guys want to talk about posterior corneal astigmatism?
So posterior corneal astigmatism is the biggest problem currently facing cataract surgeons. There is no instrument which accurately measures posterior corneal astigmatism as of today. There are instruments like like the Pentacam, which give a value, but most of the studies have shown that that value is completely unreliable when it comes to measuring, using that value in measuring the total corneal astigmatism. So, but however, posterior astigmatism is very much a real thing. So what are we going to do? We do need to know the net corneal power. So there have been certain nomograms which have been used, which basically have taken population data and kind of taken out a mean or an average of what the astigmatism would be. Like if the anterior astigmatism is this much or the anterior curvature is this much, then on an average along in the entire population, the mean posterior is something. So there is a relationship between anterior and posterior based on nomogram. For your information, the Barrett toric calculator, it already considers posterior astigmatism based on this nomogram. So if you have an IOL 700, IOL Master 700 sheet, that IOL Master 700 it also gives you the value of posterior astigmatism. And then it gives you total corneal astigmatism also. If the total corneal keratometry also. If you were to put this in Barrett into the formula, if you were to go online into the Barrett formula, and instead of putting the value of only the anterior corneal K values, if you were to put the total corneal K values, you would then have considered posterior corneal astigmatism twice, because the Barrett formula itself considers by default the nomogram, and then if you have already put total, that is anterior plus posterior, you would have considered it twice. So it's wrong. So in short, if you're ever going online and putting information into the Barrett toric formula, you must always use only anterior astigmatism. If you own a IOL Master 700, or if you have access to an IOL Master 700, you can use the formula which is inbuilt in it, which actually considers the measured posterior corneal astigmatism. It's not correct, but you can use it.
Dr. Shadab, PCA.
Yeah. So posterior corneal astigmatism, it does give you an option. The Barrett does give you an option. You can tick that you want to include the posterior corneal astigmatism or not. I do that in all cases because I don't have a IOL Master 700. I do it by a different kind of an optical biometer. So I put the values, and most of the time the optical biometers, they do have incorporated Barretts into their softwares. So you don't have to go and put it in the software. If you don't have, you can always go, it's a free software, you can do that. But I include all cases, I do include posterior corneal astigmatism in my calculations. I don't know whether it problem with all this is sometimes the patient, even after you have done a toric IOL, he or she will have some amount of residual of maybe around 0.2, 0.3, 0.5, and the patient is very happy. So you don't know whether that problem, whether the residual astigmatism is actually a problem or not. And sometimes you have a bang on result and the patient is not very happy because of some other things, like maybe because the patient has dry eyes, or maybe because your incision is not completely healed properly and that is causing the patient irritation or foreign body sensation. So I don't know whether this does make a very big difference, whether you have to calculate posterior corneal astigmatism in all your cases. Of course, we don't have something which calculates it accurately as of now, but still all patients with whatever we have, whatever technology we have, we do find the patients are very happy.
What I want you guys to elaborate on is the theory or the concept of PCA. In the sense, is it with the rule, against the rule, how it changes with time?
Yeah, so that concept, it's very difficult to explain because I also don't remember it properly. Maybe Ameya knows it.
Okay, so in general, there is this thing known as astigmatic drift. Okay, so astigmatic drift is the tendency of the eye to go from with the rule astigmatism to against the rule astigmatism. This is generally approximately 0.3 diopters per decade. That means that every 10 years, the astigmatism of any individual will change on an average by from with the rule to against the rule by 0.3 diopters. So if you're operating a 40-year-old patient and you correct the patient and get him bang on, 20 years from now, he will have a residual astigmatism of 0.6 against the rule. Okay, that's normative data. Of course, it doesn't happen in every patient, but that's called astigmatic drift. Now, that is one point I think which perhaps Neeraj was alluding to.
Yeah,
Another
exactly.
thing is,
Exactly.
That is, yeah, okay. And the second thing is the relationship between anterior and posterior. So in general, the anterior, see, it's actually, if you see the curvatures of the anterior and posterior cornea, they are the same. As in, if the anterior if anteriorly the vertical curvature is steeper, then even posteriorly the vertical curvature is steeper. But for the anterior cornea, light is going from rarer medium to denser medium. But for posterior cornea, it is going from cornea to aqueous, right, which is denser to rarer. So because of that, the light will bend ulta. Okay. So that is why anterior cornea, if it is, let's say, vertical steep and horizontal this thing. So if the anterior cornea, for example, has with the rule astigmatism, effectively the posterior cornea ends up having against the rule astigmatism.
Correct. This is what I was referring to actually. Um, Anything do you want to add on Alpin's method?
Okay, so Alpin's method is very complicated to explain in this without diagrams and so on. But just understand. I'll just explain it with my hands, whatever I can do. Okay, so it's like this: if a car is going like this and you want to stop it, so the neutralizing force is here. Now, what? Let's say a car is going like this, and you want to know what will happen if a force is given in this direction. Okay. So obviously the car is not just going to turn and go that ways. What is going to happen is the car is already going here and then it will get some force in this direction. So what you will have to do is this force will now have to be broken down into a vertical and a horizontal component. So the horizontal component will neutralize this direction of the car and the vertical component will move the car slightly upwards. So this is vector addition of these two vectors. Now in physics, opposing forces are at 180 degrees to each other. So it's very simple. You just use normal mathematics, normal geometry, and trigonometry, and figure out the addition of the vectors. It's very easy. In astigmatism, because the opposing forces are not 180 apart, because if you make an incision temporally and you make an incision nasally, it does not cancel each other. It actually doubles. It increases your astigmatism. So the neutralizing force is 90 apart. So you have to now you cannot change trigonometry. There are rules of trigonometry. So in order to make astigmatic calculations amenable to standard normal mathematics, this Alpin's guy came up with a double angle vector diagram, DAVD. So what he does is, whatever is the angle of astigmatism, okay, let's say it is at 30 degrees. Now the astigmatic world revolves around 90 degrees because the opposing forces are 90 degrees to each other. Whereas the world of physics goes around at 180 degrees. So what he said, what we'll just do is, we'll just double the angle. So if there is a existing astigmatism at 30 degrees, and let us say I am inducing an astigmatism due to my incision at, let's say, 140 degrees. So how will I add these two things? So what he says is, you just double both of them. So the 30-degree original vector, that is the existing astigmatism vector, we will multiply it by 2. So it goes at 60 degrees. And your surgically induced astigmatism, which I said 140, will now go to 280. Now these two, the one at 60 and 280, you can now use normal trigonometry. You can just use trigonometry to find out the summation of these two. Then you get a resultant vector, which is now your resulting astigmatism. Because you had initial astigmatism, you had surgically induced astigmatism, you doubled their angles, and now you have a resultant astigmatism. Now this resultant astigmatism is already doubled. So to find out its real angle, you would now divide it by 2. And that would give you the resultant astigmatism. That was that little diagram that she showed, which is basically a double angle vector diagram. And this is how it is actually done. You need not do it yourself. It can be done. It's not very difficult, but you need not do it. It's available online. You can just go there and put your values and the computer will do it for you. And also that thing is nowadays people are not calling it Alpin's method in conferences and things. They are not calling it vector analysis. People get scared of all these terms. So instead they're using the word centroid astigmatism. It's nothing, it's the same thing. Centroid astigmatism means they just do all the addition and say the astigmatism at the center. Obviously, we only consider astigmatism at the center. We don't care what's there in the periphery. So that's about it.
We have one audience question. It says, which of the two ways of IOL power calculation is more accurate? When we use posterior corneal astigmatic values calculated by IOL Master 700, or by using anterior K values and putting it in Barrett calculator? I guess you already answered it, but I think you can clarify it again.
So now there is a considerable amount of controversy with respect to this question. But in general, at least my experience has been that just putting it in the Barrett calculator and using the nomogram rather than using measured values is better. But this is personal experience. The data on this is very equivocal.
Your take, Dr. Shadab.
I think unless and until we have IOLs which are manufactured according to the exact axis and according to the exact power we need, this all the difference between the two maybe 0.1, sometimes 0.1 or 0.2, and the differences in the power of the lenses maybe 2.25 and then 3. So you might not be able to judge this very accurately because you won't have that amount of power. Like if you want to have a power of 0.6, like 2.6, do you have that? You don't have it. You can either go with 2.25 or you can go with 3. So this is all theoretical. Practically, putting the values in the Barrett and using Barrett calculator is the more easier way to do it, and that is what we do.
Agree with you, Dr. Shadab. There's one question. What could be the explanation for significant residual astigmatism after an uneventful toric monofocal cataract surgery? Post-operatively, no rotation is noticeable even after 1 month of surgery.
Okay. So for this question, firstly, now you have found that there is significant residual astigmatism. Number one. Okay. So that is, how have you found this? You have probably found this by doing a refraction. So your refraction has shown you an astigmatism. Now the next question the next thing you should do is also do a keratometry of this patient. You should do a keratometry of this patient, which you have done post-op, and you should have also a comparison with pre-op. Now you have to see whether one of the causes could be induced astigmatism, whether you have induced an astigmatism by warping the cornea, by distorting your wound or something. So is the pre-op K value and the post-op K value same or similar? If it is grossly different, then that's your cause. That's the reason why it has happened. Let us say it's not grossly different. Maybe your pre-op value itself was wrong due to tear film or something. So if there is an astigmatism, it has to be explained, right? So it can only be from two sources. Either it can be from the cornea or it can be from the lens. If your lens power calculation is correct, the lens power calculation would be correct, assuming your pre-op measurements are correct. So if your pre-op K value measurement has come correctly, for example, one of the most common mistakes which everyone makes is when the patient sits on the biometer, nobody bothers to check eye level. So the patient's head is tilted like this, and you take biometry of this eye. Then you go here, oh, the eye is not there. Now you bring the biometer, you move the joystick and make it go down and you measure it. So you think that the astigmatism is at this angle, but actually it's at this angle. So before you take the measurement, you have to be very sure that both the eyes are at the same level. Some biometers, like my own biometer, I have a Tomy 2000. So my biometer has a automatic alignment system. So because of that, even if the patient's head is tilted, if I measure this eye and I go anywhere near the other eye, the biometer automatically goes and focuses correctty. So I have to disable that system because I had to disable the automatic alignment because it was giving me wrong toric values because of head tilt. So that could be one of the reasons. Like you might have a pre-op head tilt.
Dr. Shadab.
Yeah, so Ameya explained it very well. Pre-op values are the main thing. Also, uneventful cataract surgery may be there in an eventful patient, like a patient who has pseudo exfoliation, or maybe a small amount of zonular instability. That also will lead to the tilt of IOL sometimes, and that may cause some amount of astigmatism when you check, and you'll have perfectly fine keratometric values. To check that, it's difficult. You have to do maybe an ASOCT to see whether the IOL is in a proper axis. Uneventful, I feel maybe an uneventful surgery means that the IOL is in the back. Both the haptics are in back. Sometimes one haptic comes outside, is placed outside in the sense by mistake, and that also can lead to problems in your values post-operatively.
Also, I think the lens, the alignment of the lens to the
ELP,
center.
ELP.
That is also there. So what can induce what appears to be astigmatism could also be the difference between the geometric center of the cornea and where the lens is. As in, the geometric center, the visual axis may not align with the lens and the geometric center of the cornea. So that can actually lead to a distortion in the there's this point spread function. So if the three things are not aligned correctly, there would be a distortion, which is actually a aberration. But that aberration can be partially corrected by giving cylinder. So you might actually have a aberrated wavefront, which is partially corrected by giving a cylinder, which might give you the impression that it is a cylindrical residual, but it's actually you're actually correcting part of the wavefront aberration. That is also another thing.
Usually coma.
Usually coma, correct.
Amongst all the things that you guys said, one more thing could just be a silly mistake, in the sense that the IOL was supposed to be placed on the steep axis and you placed it on the opposite axis. It can happen. These kind of silly mistakes can happen in a busy OT day. So that is also something that needs to be verified.
Yeah. Also, once, just very good point pointed out by Neeraj, once this happened with us, where our biometer had measured some K value for steep axis, another K value for the flat axis. While entering in the Barrett formula online, the optometrist might have put it ulta. The steep axis as the other one and the flat axis is the other one. So you'll get exactly the opposite orientation of the IOL which you should have. So instead of neutralizing the astigmatism, you will double the astigmatism.
Yeah, this is precisely what silly thing I was talking about. I guess we are at the end of our session. Fantastic inputs, Dr. Shadab, Dr. Ameya. We will in fact carry this forward to our next session couple of days down the line, wherein we will be talking in detail about toric IOLs and how to calculate and how to implant a toric IOL and issues with respect to toric IOLs. So this session was intended to cover the concepts of astigmatism per se, because we've noted that sometimes directly jumping to toric IOLs without understanding astigmatism and without being able to uh, calculate or extract the correct keratometry values, K values, can lead to disasters. And toric IOLs are very unforgiving, the most unforgiving, I would say. So we'll continue with that in our next session.
There's one question here by Nitish Kumar. He says, how to judge whether the pre-op astigmatism calculator is accurate if keratometry values calculated by various methods are not correlating? Then which values to take? So this happens sometimes. Okay. So you must figure out the cause. Why are they not correlating? The usual suspect is tear film. Okay. So most of the time, dry eye and unstable tear film is the cause of this problem. So when this happens, not only should you measure with different machines, you should measure multiple times with the same machine. You have to take a good 10 minutes to take like 10 readings from each machine and make sure that they're all similar. And you should shift between, like if you take 10 readings, one in a row in one shot from one eye and then 10 in other eye, you'll always get good correlation. You should take 10 from this eye, then 5 from here, 5 from there, again back to here, again back there. You should keep shifting, and then you should make sure that it's consistent. If it is not consistent, most of the time it is tear film. Now my biometer also has a Placido disc, so I can nicely see the Myers and whether they are distorted or not. And Meyer distortion gives me an idea that it's a tear film problem. If it is a tear film problem, usually at the slit lamp, at the place where I'm doing biometry itself, I would put CMC drops. Don't put viscous drops. Put basic CMC 0.5 drops so that they don't change the curvature much, and you can take the reading again. Then you see whether it matches or not. In some patients, it doesn't match. Even despite that, it doesn't match. Now, these are the worst patients to have because they are going to keep complaining about poor vision after the surgery, despite they might read 6/6, but what they'll have is poor contrast sensitivity. So they'll keep complaining that their vision is not good, अच्छा नहीं दिख रहा है, despite them having 6/6 vision. So you have to correct the tear film problem first. It could be a meibomian gland dysfunction. It could be aqueous deficiency dry eye. It could be whatever. So you got to figure out what is causing the dry eye. If it is something related to tear film inflammation, maybe give a course of cyclosporin for a couple of weeks or 2 or 3 weeks, and then bring the patient back and check it again. If it is meibomian gland disease, you should treat the meibomian gland disease. Whatever is the cause, you got to treat it. So this is one thing. Now, another thing that might be giving different values is that different keratometers measure at different diameters from the center. Like, for example, a Bausch & Lomb keratometer measures at something like, I believe, 3 millimeters, if I'm not mistaken. Whereas IOL Master, it has 2 concentric rings with little dots, and both of them are at, I don't remember, 2.2 and 2.6 millimeters or something. Okay. So, because the cornea is prolate most of the time, what happens is the center is steeper and the periphery is flatter. So, a keratometer which measures closer to the center will always give steeper values as compared to the keratometer which measures at slightly a more peripheral area. So, rather than really being nitpicky about the value itself, you should be very sure that the axis is matching. If the axis is matching, that usually means both the keratometers have measured correctly. But now you will say, okay, which one should I take? Should I take the one which measures at center, or should I take the one which measures at periphery? So you must understand that you can take either one of them. But the one which measures at the center will always give a little bit steeper value as compared to the one which takes it at periphery. So what you actually have to do is you have to modify your A constant based on your keratometer. So if for example, you were to take the one which takes it at the periphery, you will always have a slightly flatter K value, right? Whereas if you were to take it at center, you would always have a slightly steeper K value. So that much correction in the diopter. If you remember SRK formula, it is some constant into keratometry, some constant
0.9
into axial length, and minus the A constant, right? If I'm not mistaken. So you will have to give a correction to your A constant based on this difference in keratometry. So personalization of A constant is what you have to do. If your keratometer values are consistently different in your two machines, okay, but axis should be the same. If axis is not coming same, that means your tear film is not right, or that the patient has shifted his head or something like that.
And also what you can do is, if pentacam values are not correlating with your keratometric values of biometer, you take the pentacam values at the 3 mm radius. Most of the time that matches with your biometer values. The pentacam will incorporate all 3, 5, 7, 9 mm, all everything it will incorporate into one and give you the keratometry, the values which it gives. But if you take it at 3 mm or 2 mm, sometimes you will get to know what is the exact central keratometry which your biometer or your autoref will also take.
Thirdly, what I would suggest is that if you are sure that the readings have been taken correctly, tear film is okay, there's no such issue, then there is probably some element of a nebular corneal opacity which has been missed on a cursory slit lamp evaluation, or some element of ectasia happening, low grade ectasia, which will give you erratic values. Then you have to consider doing a proper corneal topography, Scheimpflug topography for this patient, like a pentacam or a Sirius, which will give you the topographic analysis of the cornea. So irregularity or ectasia needs to be considered in terms of erratic values.
Also, the last thing which can give erratic values is an erratic machine. So, non-calibrated machine. If you have been using the same machine for 4 years and never calibrated it, there might be dust on the optical element and it's just measuring it wrong. That's another point which is always missed. Nobody bothers, especially in big hospitals. And nobody takes the responsibility of doing the calibration.
What
in
do you
Sankara. In
mean big
Sankara,
hospitals?
not in Sankara we do it. I know there is a big register with calibration and all, but in other big hospitals.
In big hospitals like the eye clinic.
Dr. Dirga?
Thank you, everybody. Thank you for such valuable insights. With this, we'll call it a wrap and looking forward towards the next session in line, which is Toric IOLs.
Thank you, Dr. Ameya, Dr. Shadab. Thank you, Dr. Dirga.
Thank you, sir.
Good job, Dr. Divya.
Thank you.
Thank you, sir.
Bye. Good night.
Good night.